All right, good morning, everyone. It's officially 11 o'clock, so we will get started. I hope you all have been enjoying the sunshine we've had lately. Hope it sticks around. I'm sure everyone has already noticed, but I would like to point out that we are not using Zoom WebEx. We're using regular Zoom meetings, which is why you can see other attendees. With that being said, we would like to encourage you to turn your videos on. However, if it is lagging, we do recommend that you try turning off your videos to assist with any video quality issues. Additionally, it is recommended that you close out of any additional programs that you aren't using, as well as logging off of any VPNs or networks to help with overall connectivity. A reminder to please keep yourself on mute to ensure that everyone can hear the speakers and to eliminate any background noise. Questions can be entered in the chat box throughout the duration of the presentation. There will be two brief question and answer periods during 2 points of the meeting. At those times, we will take any additional questions. Lastly, this stakeholders meeting is being recorded for quality assurance purposes and will be uploaded to CCN's website. Again, thank you for joining us, and I would like to introduce Lenore Boris, Chair of our PAC Exec Committee, and she will be moderating today's meeting.
Thank you, Alexa. Before we start the formal presentation, I want to acknowledge that yesterday marked the 1-year anniversary of the World Health Organization declaring the COVID-19 as a pandemic. Many of us have experienced loss, grief, sadness, renewed friendships and connections, a resurgence of awareness of our personal values, and other teachable moments. Before the program, let us take a few moments of silence to acknowledge what the last year has meant to us individually and collectively. While you're silent, consider taking some cleansing breaths as you reflect on your gains and/or losses during this past year. Thank you, everybody. It was just a few days before COVID-19 was declared a pandemic that CCN was prepared to have a quarterly stakeholders meeting. It was going to be an interactive event led by the Regional Trauma Informed Care Network. The title was Partnering for Resilient Communities, a look at the health impact of toxic stress and interpersonal violence. What an appropriate topic for that day and the days we have experienced this last year. At the start of that meeting, I would have been welcoming you by reminding you where the bathrooms were and the food lines and other information you needed to be able to participate fully. I'm sorry I can't offer you food today, but such is the limits of Zoom. Businesses and our partners shifted on that Friday to move to a fully remote, temporarily closing for 3 days and reopening on Mondays. What remained consistent during this past year was the collaboration of the region, but especially by our partner organizations to ensure that communities continued to be well cared for. Over the weekend and over the weeks to come, masks were made available, non-perishable foods collected, hand sanitizers, wipes, and toilet paper were in high demand. And nevertheless, our partner organizations continued to deliver safe care to our constituents. CCN designated funding for the Community Telehealth Assistance Program to support partner initiatives to more seamlessly make the shift to a new care delivery model. 1 year later, we're still at work, and remarkably, our collective missions continue. So it's appropriate today that we acknowledge the impact of telehealth, which got jettisoned to the top of our priorities, the partner successes and the lessons learned from going remote, to learning about the regional vaccine distribution network of the Southern Tier and then a look at Care Compass strategy plan as we push forward toward the sustainable care delivery models to best practices learned through DISRIP and to ensure that they can continue to impact the community health and well-being. This presentation is packed, so we may go a little longer than 90 minutes. If you have to sign off, as Alexa reminded you, we are recording and the presentation will be available after this meeting. Highlights of the meeting will also be shared during the April RPU meetings. Next slide, please. All right, so in preparation for this meeting, we surveyed, regionally did surveys to find out what people's top concerns were for using telehealth solutions. As you can see from this word cloud, cost is a big factor, but there are other issues of sustainability, of the training that's needed both for patients to use telehealth solutions effectively and for providers to use telehealth solutions effectively. There are concerns about the quality of care offered through these solutions and the efficiency of it. There are also issues of how to adopt it, with internet connectivity being the key to the adoption. Next slide. We also wanted to find out what you wanted to learn more about. Training, obviously, at the top of the list. How do we use this new method of providing or receiving care? What kind of collaboration is needed to make it effective? Are there any regulations that needed to be changed in order to use this kind of technology? How quickly can organizations and individuals adopt this technology? And how will we ensure that clinical outcomes remain at the same level of quality as in-person care? And then, of course, regulations and whether or not there are any changes to regulations needed to carry us forward. Next slide, please. All right, we have a question for you. This is a new format, so you can see the question. We'll give you a second to answer. And then at the bottom, if you press submit, we'll be able to get the responses instantaneously. All right, and the answer should be coming up. Reliability of the access to the internet. Yes, particularly because we know across the CCN area, we are predominantly rural, and internet connectivity is a major concern, not just for people to stay connected to one another, but if we are to reliably use telehealth in the future. All right, if we could move on to the next slide, please. All right, now we have an update on the COVID-19 telehealth activities of the past year. This will be presented by Dr. Wayne Terrace, who's the Chief Medical Officer for Care Compass Network, and Jim Rock, Telehealth Program Manager for Care Compass Network. Take it away.
Thanks so much, Lenore. And good morning, everybody. Great to be with you on this beautiful sunny day. So I will be providing some background on telehealth prior to handing it over to Jim to talk specifically about the CTAP program. And if we could go to the next slide, please. We have another poll question. So if you could go ahead and answer that and submit, we'll see how the answers turn out for this one. How many times have you personally used telehealth in the past year? Okay, so 1 to 5 times, 48%, and not at all, 42%. So the 48% who have used it does speak to the fact that that the COVID pandemic has really exponentially increased the adoption of telehealth by necessity. But you know what? I love these historical viewpoints. And if you look at this, actually back in 1924, if you look on the left, the Radio News magazine had an issue where they talked about, well, maybe we'll have the radio doctor. And you see the little guy, opening up to have the doc look at his sore throat over the radio. And on the right, you have another article where the clinician is actually using some sort of remote device to help diagnose his patient remotely. So, wow, that was a long time ago. Next slide. But we're actually ahead of the game. So those of you who remember the Jetsons, one of my favorite cartoons when I was a kid, we have Elroy Jetson with a sore throat, and there's the teledoc, interestingly wearing a mask, and I'm happy to say he's wearing it properly over his nose and his mouth. But at any rate, this is a 1960s cartoon set in 2062. And, here we are this year, and we're really there. So we're 40 years ahead of the game. That's awesome. Next slide. And, just looking, we have a really robust IT infrastructure at CCN, and I just wanted to briefly show you where telehealth fits in. So the base of the pyramid and where we started really was the basics, electronic records, RIO connectivity, and then of course we've stood up population health and care management systems, but the apex of the pyramid is really our telehealth program. Next slide, please. And other than the CTAP, of course, we have a lot of other projects, and I just wanted to briefly highlight a few. We had a very large program where we set up systems to provide medical, mainly off-hours consults and scheduled behavior health consults at skilled nursing facilities, initially piloted with 6 partners and since then expanding to 12. Extremely successful. We've reduced preventable visits to the ED in the 25 to 28% range. Gerald's Pharmacy, of course, has a robust telemonitoring project for respiratory patients. Tioga County Mental Hygiene implemented an e-visit project to provide behavioral health services to rural patients. And this was stood up just before the pandemic. And that was really fortunate because of the situation that the pandemic created. And finally, Springbrook implemented a variant where they were using pre-existing equipment to serve the IDD population. So it just really goes to show you the variety and the breadth of our projects. Next slide. So what I wanted to do was just level set a few definitions here. You've all read about telemedicine, telehealth, virtual care. And if you research it, you see a lot of different definitions. And I really wanted to kind of keep this simple so you had a good understanding. So this little graph is sort of like Russian nesting dolls, right? If you start with telemedicine, that is really very specific to the practice of medicine using telecommunications, delivering care at a distance. And then that is really included within telehealth, which was the broad collection of technologies that support healthcare delivery. So telemedicine is really the clinician and the patient. Telehealth is a much broader definition. And finally, virtual care really encompasses both. It's all the different ways healthcare providers can remotely interact with their patients. Next slide, please. Looking at it another way, again, as I said, telemedicine refers specifically to the remote clinical services, and telehealth, in addition to all those technologies I just alluded to, it really includes everything else. So provider training, administrative meetings, continuing medical education, other clinical services, patient portals. This is the broad definition of telehealth. Next slide. So there are really 3 solutions in terms of telemedicine. The first is what we call store and forward, or asynchronous telemedicine. So this is when data is collected by a party and then sent to another healthcare professional at a later time. No interaction between the patient and the provider. So for example, if you have a primary care professional who wants to engage with a specialist, they could send x-rays, MRIs, photos, patient data, videos, etc., which is done asynchronously. Next slide. And then we have remote monitoring, where patients collect and upload health data while at home using a device. They can include or not include real-time interaction with a provider. And really, this allows patient data to be gathered outside of traditional settings. And it's really ideal for empowering patients with illness to take an active role. Next slide. And this is the solution most of us think of. This is teleconsults or virtual visits. This is a real-time live interaction between the patient and the provider using audio and video. It can occur anywhere. And virtual visits allow for timely access to care and facilitates communication. And we all know now that this will enable reducing costs, increasing access, and improving chronic disease management. Next slide, please. Just another way of looking at this, a taxonomy. So on top, you have telehealth. Beneath telehealth, you have education, patient portals, and you have telemedicine. And then within telemedicine, you have store and forward, you have remote monitoring and interactive patient care. Next slide. So we are really proud of this. You know, we had obviously an acute crisis last year. Everybody had to shut down suddenly. Wow. And so CCN in mid-March conceived this concept, and by April 3rd, we were open to receive applications, and the final application period closed on May 8th. So this was rapid turnaround, and it really met a community need. And with that, I'm going to hand it over to Jim to discuss the CTAP program in detail.
Thank you, Dr. Terrace. As Dr. Terrace mentioned, I'm going to go into a little bit more detail about this program and its features. This slide here gives us an overview of the CTAP and how it was structured. First off, I want to clarify this program was intended for non-hospital, independent PCPs, and community-based organizations. These types of entities typically have less resources than a hospital or health system to respond to a situation like the pandemic and the lockdown. And we wanted to make sure that we could provide assistance to organizations that might have otherwise been forgotten about or lost in the shuffle with all the chaos surrounding the pandemic. There was a lot of attention on hospitals and health systems by both the media and government agencies early on in the pandemic. It seemed that no one was really looking at how this was affecting smaller organizations, also a key role in the healthcare system. Our goal was to have a significant impact and assist as many independent organizations in the Southern Tier as possible. Now, the program was designed to cover not only equipment costs and setup fees, but also any recurring service fees for platforms like Zoom or Doxy for up to 1 year. This was intended to help organizations get through the lockdown and beyond. The hope being that a year later, things would be looking brighter and the worst would be behind us. So here we are pretty much at that point, about 11 months after the launch of the program. It seems like we're still in the thick of the pandemic. However, the fact that we're getting a lot more people vaccinated every day and things are, the numbers seem to be trending in the right direction. I think that gives us all some hope. We are in the home stretch of this crisis. Now, the program provided a maximum of $50,000 per awardee, and interestingly enough, only 3 applicants sought that amount and were awarded the maximum amount. The other 31 applicants were all over the map dollar-wise, with the lowest being in the $2,000 range. We had a few small ones like that, and the rest were everywhere in between. Also, the funds were dispersed based on actual invoices, and it wasn't just a lump sum handout. This was a reimbursement model. We do require quotes up front so that we would have a relatively accurate estimate to include in the partner's contract. The funds were ultimately paid out against actual vendor invoices. The program was not meant to provide funds for anything that the partner was expecting to receive funds for elsewhere. Remember, our goal was to stretch our funds to assist as many organizations as possible. So if someone was receiving other assistance for a telehealth initiative, we didn't want to double fund one organization while another organization might be left with nothing. We put that criteria right into the application process. All of the applications that we received, we ranked using a rubric that we created. This was developed based on a number of criteria, such as demonstration of need, a number of Medicaid lives served, and a few others. And this was done in the event that if we had too many applicants to fund, we would be able to rank them so we could defend our decisions on who would receive funding and who would not. Fortunately, it did not come to that. We were able to award all 34 applicants the full amount that they requested. And finally, one of the most important features of the program was the rapid turnaround time. As Dr. Terrace alluded to a little bit earlier, due to the urgent nature of the situation, the fact that many of the organizations were really hurting, we wanted to make the process as streamlined and efficient as possible in order to help these partners continue operating, serving their patients and clients. And as you can see, we achieved that goal by taking the program from concept, awarding 34 partners in less than 8 weeks, which we felt was a pretty good turnaround time. And we are very proud of the fact we were able to do that. On this slide, we have an overview of CTAP by the numbers. Although we had originally budgeted $750,000 for this program, and the initial maximum contract amounts were in excess of that, we ultimately paid out significantly less dollars than expected and came in under budget. This is primarily due to the fact that we were paying out based on actual invoices incurred and not just handing out cash to be spent at the partner's discretion. Our finance department is very meticulous when it comes to documentation, and they made sure that every penny had to be accounted for. Also, we have the number of awards by organization type. We notice that the number of organizations on the left add up to more than 34. This is due to the fact that we allowed the applicants to identify as more than one type, and several of them did. You can also see by this graphic that mental health providers and social organizations make up the vast majority of our funding recipients. Next slide. This graph shows the breakdown of telehealth platforms that the participating partners selected, with Zoom being the most popular choice. This is probably reflective of the telehealth industry at large, with Zoom being one of the industry leaders in that space. Now, the main reason I included this slide is not the vendors, but to talk a little bit about how we've worked to add value to this program. When some partners first applied for this funding, they were in dire circumstances. Their regular operations had been shut down due to COVID, knew they had to do something to try to function remotely, but maybe they had no idea where to begin or even what questions to ask. I spoke with each one of these partners individually, and we asked them, what are the problems that we're trying to solve? What are the specific problems that are affecting your organization right at this moment? And then we would go from there, help to guide those partners who were at a loss in order to recommend solutions. We share what other partners had learned and how that had worked. We didn't see our role as just the bank handing out money. If an organization had no idea where to begin, they can have all the funds in the world and it's not going to make any difference. We saw ourselves as a technical resource, providing information and guidance to help them navigate a very difficult situation. This is where CCN really added value to this whole process and helped ensure the success of the program. Next slide. On this slide, we have some actual verbiage taken from the CTAP applications. This illustrates the broad range of challenges faced by different organizations and the impact the lockdown was having on the vulnerable populations that they serve. Here, we had a private practice physician with telemedicine to focus specifically on the patients, mental health, behavioral health issues. There were a lot of different challenges, as we can see here. Mental health providers, social organizations, substance use providers. There's a broad range of issues that we were trying to address, and it seemed like a pretty daunting task at the outset, but we were able to navigate it pretty successfully. All these examples highlight how many individuals were receiving services from these organizations and how those services had suddenly stopped as a result of the lockdown, with virtually no notice and with no alternative plans in place. These were exactly the kinds of organizations that we were targeting and exactly the kinds of problems that we wanted to solve. The lockdown was effective at slowing the spread of COVID, but the price that was paid was an exacerbation of many of the other medical, behavioral health, and social ailments. This is where the CTAP came in to provide relief to the organizations in the Southern Tier who were battling all of these other ailments. Next slide. We talked a lot about what we were trying to achieve with the program and what our goals were and the problems we were trying to solve. The next slides, we're going to get into to look at how we did, if we accomplished our mission. We feel that the best way to gauge the success of the program is by talking to the partners who were on the front lines using the program and see how they felt about it. So with that in mind, we sent out a survey to all of our partners who participated in CTAP to get their thoughts on the program and its impact. We can see here the results of that survey. We had 39% of those surveyed felt that the program was absolutely critical to their organization's survival during the lockdown, with another 33% saying it was very important to the organization. The remaining 28% felt that it was a helpful supplement to what they were already doing. There was a fourth option on the survey that stated that the program was of minor importance to the organization. And as we can see here, no one selected that option. So all participants found the program at the very least helpful, and 39%, or about 13 organizations, felt that they may not have survived without it. That to me is a pretty significant number. It's kind of scary to think that the pandemic permanently shut down 13 organizations that serve the people of the Southern Tier without the CTAP program and the assistance provided by CCN. Now, these numbers alone would have made people considering the program a smashing success. I feel the real success of the program is measured by the actual results on the ground, the direct positive impact it had on thousands of lives in the region. So with that, we'll go to the next slide. And we've got a poll question. The question, when you think of this coming fall, what % of your clients do you anticipate using telehealth services? So we have a variety of choices here, 0%, 25, 50, 75, or not sure. So if you want to take a quick moment and make a selection that best applies to your organization. We'll see what our results are. Okay, so what % of your clients do you anticipate using telehealth services? Looks like the largest number, 40%, feels that at least 1 in 4 of their clients will be still using telehealth services. 20% feel that at least half of their clients will, and 11% feel that 3/4 of their clients will. So that's pretty significant. We've got over 70% of the respondents here feel that there'll be some significant telehealth usage by their clients in the coming months. So I think that highlights what the pandemic has done for telehealth. I've said many times that one of the few silver linings to come out of this whole crisis is the fact that it has accelerated telehealth probably by years over where it would have been under normal circumstances. So, and I think this poll sort of reinforces that fact. Next slide. At this point, referring back to what I said about getting some direct information from the boots on the ground, the folks who were on the front lines, serving the clients, we're going to hand this off to 3 of our partners. The first partner that's going to be talking is the Cortland County Mental Health Department. And we have Sharon and Nancy from there who are going to be providing that information. So at this point, I'm going to hand it over to Sharon to get started, and we'll take it from there.
Thank you so much, Jim. We really appreciate this opportunity. We're going to quickly go through 8 slides to kind of tell you how this worked for us with our mental health department. First, I have to start with our thank you to Care Compass Network for the opportunity to present today how our mental health department was able to successfully use the CTAP grant. Our office manager, Nancy Smith, and I will offer you our success story in utilizing this grant for telehealth services in our outpatient mental health service programs. Special thanks has to go to Jim. He's not kidding when he just talked to you about being a resource to us to implement this for our success. Next, let me just briefly review again the next slide of the CTAP purpose. I know Jim went over it, but it was an opportunity for us as established partners with Care Compass it gave us a place to turn for support when we really needed it the most during this pandemic when it started. The CTAP grant offered us the ability to expand our telehealth rapidly in response to our clients' needs. You can see here one of our clinicians in the photo when we were able to finally utilize some laptops and be able to do the telehealth remote access. On the next slide, I'm going to summarize what we did. Cortland Mental Health rapidly transitioned all of our treatment and services to telehealth through technology investments. I'm going to get into some more details later on about that, but the CTAP was the solution that was at the absolute center. It brought together our key areas of successful telehealth: our electronic health record, our clients, our workforce, and our technology. I'm going to touch on those throughout the presentation briefly. Our adaptability and collaborative approach as a team really allowed us to both purchase and implement technology that was critically necessary for our telehealth success story. I'm going to transition next to our office manager, who's going to talk about how we were able to implement our CTAP grant.
Unmute. Yes, so you can see the elements that we had for our 3-month rapid ramp up for implementing of the CTAP to our services here. Purchasing hardware and software, working very closely with our IT department. It was a major process. We had many supply chain struggles in this course that had to be addressed. IT was critical in that and helping us find things. So let me break it down a little bit more specifically. So software expansions, we had to expand our EHR, and fortunately our EHR has an integrated HIPAA secure video telehealth system, which we rapidly expanded into our telehealth service, our telehealth success. Our integrated security software that we worked with IT, they increased our patient portal software as well that we were able to do through CTAP. We also had many hardware expansions, including the computer upgrades through the laptops and purchasing monitors that had integrated webcams and microphones within them. And that was really critical to support the video telehealth that we needed to achieve with our clinicians and clients. We also purchased a wall-mounted interactive touchscreen, like smartboard as you wish, for our groups to do group treatment and hybrid in-person and telehealth groups. So let's discuss the lessons we learned next.
Thank you, Nancy. Here you can see some of our key lessons we learned implementing telehealth using the CTAP. We have to include this wonderful photo of one of our clinicians who was thrilled when she got the large wall-mounted monitor Nancy just shared about, which allowed her to do these hybrid groups. Balancing workforce and client needs for successful telehealth required some really quick adaptation and solution planning. Collaborative communication was so key across our department, our IT department, our workforce, and our clients. Increased communication, training videos, and instructional fact sheets became key in the remote work environment for success. Nancy, I know you want to share some more specifically about being a compliance officer.
Right. You know, obviously it created some compliance issues. And so we needed to be much more thoughtful around HIPAA and our IT security increasing in this telehealth environment. And that had to be addressed. As a rural community, access to broadband internet and technology was a limiting factor for our staff and the clients. As an example, many of our clients, if were trying to access telehealth services, if they had their mobile cell phone, they could use up their monthly cell minutes in just one telehealth session, unless they found a Wi-Fi signal instead. So that kind of brings us to sustainability as our next topic.
Once the CTAP allowed us the full capability to offer video telehealth services, we were able to update our license with OMH to add telemental health. So some of you may know the telemental health license is a requirement, and it allows us to continue telehealth services post-pandemic to sustain this effort. Telemental health requires, though, video sessions with the client. Currently, telephone sessions are only allowed during the pandemic. We're working very closely with our state partners because we're advocating strongly for regulation changes to further improve access to telehealth services. Payers supporting telehealth is vital for the future sustainability of this effort. Next, let me describe how adding value to our services, short-term and long-term. We really believe our value proposition has improved because of telehealth services, in addition for our community, our payers, and our workforce. Here you can see some of the key factors of improvement to our stakeholders. As example, during recent snowstorms in January and February, instead of having to close or cancel our sessions, we were able to transition them to telehealth successfully. So we believe there's some meaningful support here to our community and our clients and our workforce. As evidence of early success of our telehealth, we've been tracking the number of video sessions offered through our Meta. Previous slide, you can see the numbers here for the number of sessions we were able to have. In the third and fourth quarter highlighted, you can see that 1/3 of all sessions have been offered by video telehealth by our services. That's 1/3 of all seen clients were seen by video. The others were either offered services by telephone or face-to-face. Preparing post-pandemic, we know tracking this will be critical, knowing phone calls won't count very soon. Next up, let me end with our success story. We're very happy to share that the grant allowed us to get a large wall mounted monitor that Nancy mentioned earlier. It offered this in-person and virtual groups together. This photo can show you how they could see each other for the first time. They missed each other greatly. Few of the clients in this program had other social supports. One of the members of the group was only able to join by phone and told her husband how much she missed seeing everyone. Due to her medical issues, the risk was way too high for her to join in person. Her husband was able to upgrade his phone internet service and worked with our staff so she could learn how to join virtually via the video telehealth. She and the group cried when they were finally able to see each other for the first time. It's all thanks to this grant, and her family closely collaborating with our staff. It was a very touching moment for everyone. OMH is also very impressed by this hybrid approach. And when we updated our license with them, we believe that we are still the only day treatment program in the whole state that's taken this telehealth hybrid approach. Lastly, I just have to give my personal thanks to Nancy Smith. Her incredible purchasing ability to coordinate this with our IT department was just amazing. And to end, our humble thanks so much to Care Compass for this grant to keep us and our clients connected throughout this pandemic. Thank you so much.
Hey, thank you, Erin and Nancy. We appreciate you taking the time to share your story with us. Next, we're going to go to Cindy Martin from the Rural Health Network of South Central New York. So Cindy, I'll hand it over to you.
Thank you, Jim. Rural Health Network approached this grant opportunity from two perspectives. We quickly, like many organizations, had to figure out how we could keep our staff working outside the office during the early parts of the pandemic, particularly. So we looked at two components. We wanted to provide the technology that we needed to enable our frontline staff to be remote and still connect with their clients. This was especially important for our Get There Mobility Management call center, where The staff were used to working as a team in basically one suite of our office building and often collaborating with each other on projects. We also had a couple of our community health workers that did not yet have a laptop that could be used to work remotely at the time the pandemic was issued. And I believe we also had one staff member, although the grant didn't pay for this part, we had one staff member that we provided a stipend to enable that person to have internet access, because otherwise they wouldn't have been able to continue their job remotely. We also looked at the opportunity to implement a telehealth pilot project with our Northern Broome CARES program, which is a NORC, or Naturally Occurring Retirement Community program funded by the State Office for Aging. We collaborate closely with Broome County Office for Aging and other partners to provide medical and social supports to clients 60 and older in the towns of Lisle and Triangle. We selected that community for this pilot because we knew it was a confined geographic area, a small enough client base. We served a little over 100 clients in 2020 that we could work with. So proceeding from there, go on to the next slide. Just to give you an idea of how we had an impact on clients, the Get There call center between March and December of last year, we had 7 staff working, utilizing laptops, and most importantly, the voice over IP phones that we purchased with this grant so that they could be connected through internet phones remotely. During that time, they handled calls from nearly 1,300 clients, and we purchased a Zoom for Health account. Our staff were already used to using Zoom for some meetings, but we did not have the HIPAA compliant version of Zoom. So we purchased that, and that was utilized 46 times by the Get There department during that time period, primarily for them to case conference with each other. Our program for Get There was already a telephonic support service, but that concept of the group meetings that they would have to compare case notes and brainstorm ways to meet some specific unique transportation challenges needed to still happen. So we were able to do that and discuss clients by using the HIPAA compliant version. Next slide. In the Northern Broome CARES program, we purchased 10 electronic tablets and 10 mobile jetpacks, knowing that it was an area where internet availability was problematic for some people. Many older adults that we were serving did not already have a home Wi-Fi system or a home internet. And as Nancy and Sharon mentioned earlier, if they had a mobile phone, it might not be one that could have supported the bandwidth for electronic appointments. So during, again, that same time frame of March to December, 13 unique clients used a tablet to virtually connect with a healthcare provider on 18 different occasions. 9 clients used a tablet for a wellness check with one of our staff members, which includes a contract with a Lourdes nurse navigator that works with our clients as well. And then our staff provided technical assistance at least 21 times to assist clients new to the technology. We found that one of the biggest support services we could provide was teaching someone how to use the technology. So our community health worker with that program actually created a step-by-step guide to how to turn on the device, how to connect it to the internet, how the jetpack worked, and how they could actually work with their healthcare provider through this technology. We found that healthcare was not the only important use for it in this telehealth program. So move on, next slide. The clients didn't just connect with their primary care providers. We also had clients connecting with their mental health providers. We assisted a client in scheduling a vaccine appointment. Now that was in that time frame from through December, which they weren't even widely available yet. So we've since assisted at least 20 clients in utilizing technology to access their vaccine appointment. We've assisted clients in receiving their stimulus check. We've addressed loneliness and social isolation by using the tablets to connect with virtual exercise classes offered by the Senior Center. We were able to help a couple connect virtually to their grandchild's Zoom birthday party. These might sound not that important, but social isolation and loneliness were one of the biggest issues we were finding among our clients during the pandemic. And so for these clients, that connection was their lifeline. Over 60% of the Northern Broome Cares clients live alone. So during the pandemic, they were lucky to see anybody. And we greatly increased our telephone outreach, particularly early when we essentially as an agency for safety reasons decided to discontinue home visits. We have started to reinstitute home visits since then, but we were really connecting with people via phone for quite some time. I wanted to share just a couple client interactions that our community health worker in the CARES program shared with me. One significant success story was with a woman who struggled with depression and anxiety long before the pandemic, but for which the pandemic basically ramped up both depression and anxiety. And she was really concerned that she was unable to physically attend appointments with her therapist. We were able to connect her with the tablet, and she's used the tablet on more than one occasion now to connect with her therapist via a telehealth appointment. Because she was able to get that assistance, she has since told our staff that she didn't think she'd still be here if we hadn't provided her with a solution that enabled her to get the medical assistance she needed. Her rural internet location, or her rural location, didn't support typical internet options. So the Verizon hotspot that we provided was the only viable way that we could connect her with that technology. We wanted to talk briefly about a couple lessons we learned. If anybody were to replicate this kind of project, we know that the logistics of a loaning program with the tablets and jetpacks would have been problematic in a larger geography. And we're looking into what that would mean for us if we were to branch similar options out into other communities. Also, we probably could have done better homework on the actual coverage of existing Wi-Fi providers or internet carriers in the community. So for example, we chose Verizon Hotpacks because the agency already had a relationship with cell phone service for some of our staff with Verizon. Easy to add to our existing plan, but it may not have been the wisest choice for the community we were serving. It worked in some areas, but may not have been the best solution for all of the areas served in that Northern Broome area. Some things that we felt worked really well, the voice over IP phones were such a good solution for the Get There staff that we're now looking at a voice over IP system for our entire agency phone system. We also were already having some agency conversations about the future of telehealth and perhaps teleeducation for health issues. And so we were, at the same time, we've been designing a new conference space in our office area, which we haven't been able to use since the pandemic started, but we have the technology on order that would provide a similar solution to what Nancy and Sharon shared with the interactive monitor on the wall, so that we can offer some of our educational programs through group sessions in that room. So those were not covered by this grant, but already in the plans for our future. And we've upped those telehealth conversations, brought in some representatives from some of the major healthcare systems in the area to help us make some future plans for how Rural Health Network can help support telemedicine and telehealth. We're not clinical providers ourselves, but we can provide those support services to help educate clients in accessing their own healthcare providers. So we're looking at sort of what's our role going forward, and we definitely learned things through this project that will be impactful going forward. So thank you very much.
Okay, thank you, Cindy, for sharing RHN's success story with us for the CTAP program. Now we're going to move to our final partner presenter, George Dermody from the Children's Home of Wyoming Conference. So I'll hand it over to you, George.
Thank you very much. It's really a privilege to be able to be a part of this Care Compass conference and day, because I think it almost epitomizes the Children's Home relationship with Care Compass. We knew we wanted to belong. We didn't always knew where we fit in. You know, as a child welfare provider, an education provider, social service, it seemed like we hit a lot of areas, but I didn't know where exactly we fit in. And Care Compass has been welcoming and engaging and guiding us, and we are so appreciative of that. And I think that continued through this process, you know, certainly this process for us. And I certainly want to echo the other presenters in that Jim was so helpful in asking questions we didn't know we needed to ask, helping us walk through things, and making sure that we were getting what we needed to be helpful. One of the things about the Children's Home, or any organization, you may know, that's 110 years old and in a community, is many people will say they've heard of it or they know about it, but probably know very little about actually what's happening and what's going on. And I think certainly the pandemic brought that to the forefront. Many people think of the Children's Home as just the campus that we have in Hillcrest and the children that live here. But most of our work is in the community. Most of our work are with people who sleep in children who sleep in their own beds and at night, and with families, you know, certainly throughout the Care Compass network. And so for us, the pandemic and the pivot had to be quick, and it was slightly different. So, I mean, I'm happy to say, or have to say, that as a provider, we couldn't close. We didn't close, but we had to immediately figure out, how are we going to stay connected? How are our children and families going to stay connected? And I think one of the wonderful things about Care Compass and our relationship and in our community is that we're often good at, in our world, of diagnosing problems, understanding problems, but the solutions sometimes seem just beyond our grasp. So the work with Care Compass and this project really kind of made those solutions more attainable. COVID showed us that the children, what we've known, but brought to light, the children and families we work with, the trauma, the social determinants of health that they experience or lacking, people are right on the edge. You know, certainly the food insecurity, the insufficient housing, the transportation challenges, and the lack of technology, you know, the lack of reliable internet access, those things that were so present and just popped out from day one, were really issues that we needed to address and wanted to make sure that we could help overcome. Next slide. So, as I am prone to say, and we say around here, thank God for Care Compass Network. It's hard to imagine our community without Care Compass and the work that you've done. Our approach was very simple. We iPads with built-in Wi-Fi, tough cases, charging stands, and tracking software so that we didn't create other problems, you know, in terms of inappropriate access, and we made it to do that. We used our devices in 4 main ways. Visits between family and youth. Certainly we had to restrict access, and when visits and appointments couldn't happen, we needed to keep connectivity. One of the primary indicators of family reunification is ongoing and consistent contact between parents and caregivers and their children when they're not in their home. And so losing that bond could be devastating. And there was a real sense of needing to keep contact and to try to explain, although your parents can't be here physically, they can be connected to you, and to do that. Often a large part of our work are community-based services, being able to do health checks. And although our people spend a lot of time on porches in masks and gowns, dropping food off and checking on families and doing safety checks and wellness checks, it was great, again, for children in foster care to connect with their families in our preventive services and supportive, to be able to have greater input and connectivity, and for people to ask for support as they needed it. A large part of our work here at the Children's Home is our day school program, and keeping children connected to their education services. We work with children who haven't had a lot of success in school previously, and it's our ability to connect to them, keep them involved and engaged. And that was so important. And the fact that we could do that so quickly with Care Compass's involvement really was of tremendous value and helpful. And again, our clinicians have grown and developed in their ability to keep people connected with families and parents and provide those updates and move forward. You know, so much of the work that we do is about, is living and dealing with the effects of trauma. And certainly for the children and families we serve, their trauma is real and pervasive. And COVID and all that has unfolded is just another aspect of the trauma. And certainly the telehealth program was one way we could help mitigate that. It may seem pretty simple and straightforward, but it is real, and it was profound in terms of what we were able to do to help keep that type of connectivity. Certainly one of the other biggest challenges for many of the families we work with is that loss of control. It's often what the system or what life or what experiences have done to me, and how we don't have control over that. And certainly I think that's something we all have experienced this past year, is a loss of control in our own decisions and doing. The telehealth program gave people a little modicum of control, their ability to engage, their ability to reach out. And that was so important and so profound. So our lessons learned, technology works. Technology works in human services. I was happy to hear Sharon talk about, going forward and their licensing. We feel like our state partners have seen the light. They've kind of moved forward where regulations were slow and there were always remarks on, oh, we can't do that. We have now found out that, we can do it and it works. And so certainly I don't think any of us, or else we don't want to go backwards. We want to continue to explore and to see how this important tool can assist us in our work. I do think I know there's been a lot of conversation, but we have a lot more to do on overcoming the digital divide, on dealing with lack of internet access, lack of devices. How are we going to manage that? And certainly also the technology training or teaching. I'm probably very, privileged in that I know how many times a week or a month or this past year when I've been able to call for IT support, call for help. It's not working. What can I do? And somebody comes to help me figure that out. And so helping families navigate the technology, training and education, I think is very important. So this project has made a real and important step forward in our work, in our ability to help families stay connected and to help young people, deal with the trauma in their lives. And I will end where I should begin. For us, thank God for Care Compass Network and the guidance and the support that you've provided us. So thank you very much.
Thank you, George. And also thank you to all of our partners who have taken some time to share their stories with us today. And now we're going to open things up for if there's any questions from the audience on anything we've talked about.
There aren't any questions in the chat box, but if you do have any questions that you'd like to add, either if you could just please raise your hand, that's in the reactions at the bottom of your Zoom toolbar, or if you could just place the answers in the chat box, that'd be great.
It seems no one has questions. You see on the slide the contact information for Dr. Terrace and Jim. So if you do have questions after this presentation, I'm sure you can reach out to them and they'd be happy to answer your questions and assist you. Thank you for our partner organizations and providing a summary of their telehealth activities the past year. I think it was very informative and helpful to understand how the dollar CCN can provide has a real impact on providing services to people. Next, we want to pivot a little bit and hear from John Carrig. John Carrig is President and CEO of United Health Service. He's also leading the regional vaccine network of the Southern Tier. So he's here to provide us an update on current efforts to address the pandemic in our region. John.
Thanks, Lenore. Hello, everybody. Hope you can hear me. I'm going to share a screen if that's possible. You can bear with me 1 second. Okay, can everybody see that?
Yes, that's good. Thank you.
Okay. Well, first of all, thank you very much for the invite. Really my pleasure to join you this morning and now this afternoon. I've been listening in for the last 45 minutes or so, and I really appreciate hearing all the information that's being shared. So I'm here to talk a little bit about the vaccination efforts statewide and here in the Southern Tier. I was asked to spend most of my time on health equity, and that's what I'll do. But I'll give you a little bit of background of how things have developed over the past now 13 weeks since the vaccine has been available statewide. So this regional network of vaccine hubs was set up in late November, early December, and Southern Tier kind of mirrors the regional economic development region and there are 10 of them throughout the state. And each of these vaccine hubs is led by a healthcare institution. UHS was honored to step up to serve in this effort. It's been quite an interesting process, as you can all imagine. The vaccine rollout at times has been confusing. It's been complicated, but it's also gained some traction in the past couple of weeks. And so I'll tell you a little bit about that. So there is as you know, a historic effort to vaccinate our population throughout the region, throughout the state, throughout the country. Many of you, I'm sure, heard the president last night with some new goals for us to meet, making everyone eligible by May 1st, and really trying to open up how the vaccination process is working. So as of today, Southern Tier, and you can see the 8 counties of the Southern Tier, Steuben County all the way out to the west, Delaware County to the east. So the 8 counties, we have delivered into arms about 140,000 first doses out of 660,000 people in the Southern Tier. And you know, we're following that data on a regular basis, on a daily basis. 1 week ago, when we were still measuring by percentage of first doses allocated versus delivered, Southern Tier was at 99%. Now the metric that the state is using is, you know, how many vaccines are we getting into arms within 24 hours and then over a 7-day period. But our numbers at this point are over 140,000. And we have about 72,000 people who have been fully vaccinated. So for the most part with first and second doses. So that's pretty darn good, I think, given, you know, how difficult this process has been. And the process, most of the difficulty has been the scarcity of the supply of vaccine, as we all know. So there's been a couple narratives that have been important: scarcity of the vaccine and how it's been delivered, and who's been eligible, and, you know, 1A and 1B, and then subsets of 1A and 1B, and then 75 and older, and then, you know, on a Monday, all of a sudden 65 and older, and then earlier this week 60 and older, and then a week next week will be any vaccine provider can vaccinate anyone. So there's been shifting sands under our feet, and I think we've been able to adapt to all of that. Part of this process naturally is political, as we know. I won't comment too much about politics in Albany or statewide, but we know that federal policy, federal politics, a change in leadership in Washington, you know, so many things have happened over the past 13 weeks that you can imagine how we've tried to deal with that. So that gives you a sense of the kind of the overall picture. We've had a plan in place since the middle of December, and you can see a variety in this org chart, excuse me, this org chart of how it's set up and the types of things that we're looking at. And if you look in the middle maroon, if you will, we see operations, planning, you know, how all of this should work, how we're engaging folks throughout the region. POD stands for point of distribution. So we've got commercial pharmacies as part of this. We've got hospitals. There are 15 hospitals in the Southern Tier region. We've got dozens and dozens of retail pharmacies. We've got FQHCs. We've got 8 county health departments, 8 county executives to deal with, and all of those opportunities to coordinate, and how we manage all of this. We've got a regional advisory task force. We've got education council, but maybe most importantly is right there, the health equity task force. How do we make sure, as we're delivering hundreds of thousands of vaccines over the next couple of months, for example. Now that we're moving beyond the immediate priorities, how do we make sure that access to the vaccine is fair and equitable? How do we make sure that people understand that it's safe and effective? How do we make sure that there's an understanding that many folks can answer questions? How do we get to the very rural nature of the southern tier? How do we get to some of our urban neighborhoods? How do we make sure that there is equity in this process? And that's what I thought I'd talk a little bit about with you today. So the Regional Advisory Task Force includes all the hospital CEOs, the county executives, local health department leaders. Mark is a member of that, chambers of commerce. Education and engagement really is focused on, as the title says, making sure that as many people who have questions and hesitancy, vaccine hesitancy, we can address that. And we have lots of people who are involved. The Health Equity Task Force, and I think I saw Myra is on this call, led by Myra Garcia from the American Civic Association and Lori Welsh. I'm sure you all know both of these folks. We asked Myra and Lori to be involved. We asked them to lead this effort, to develop a task force, to be partners with the hub, be partners with all of those folks I talked about, all the hospitals, all of the pharmacies, all of the FQHCs, all the counties, and it's a big task, with these, and you can see the kind of the basic goals that are noted in each of the boxes here. We have many seniors that we have to deal with. More than 20% of our population are 65 and older. We have many comorbidities. Our region, as many of you know, is not the healthiest when we look across the state. We have underserved households, we have underserved neighborhoods, we have disenfranchised folks who have not had easy access to the healthcare system. And we've got socioeconomic issues throughout our region that we need to pay attention to. And all of that kind of plays into this. So we greatly appreciate the time and effort that Myra and Lori and many others have put into this effort. And it's ongoing as we speak. This was the kind of the Zoom snapshot of folks who were on the task force meeting earlier this week. I'm sure you see familiar faces and names. And this was, I'm not sure how many are here, 20 or so, but we've got 27 different organizations who are represented by the Southern Tier Health Equity Task Force. And we've got faith-based organizations who are represented, folks from housing, migrant farm workers, and various advocacy groups, individuals with disabilities who have difficulty, getting to a mass vaccination site. One of the reasons we need to get vaccination into neighborhoods and into farms and into the rural areas. We've got folks from education and higher education represented, the Black and brown communities, immigrants and refugees, just about anyone you can think of is represented by this Health Equity Task Force. So education and outreach, as I said, is really something that really is important. And we've tried to be as inclusive as possible. You can see a couple of the information sessions that we've held. All of this information, by the way, is on southerntiervax.org. And southerntiervax.org is a website that we set up maybe a month ago or so, as things were really getting rolling. And since that time, just in 1 month, we've had something like 60,000 hits on this website. There is great interest in the vaccine effort. And, you know, that 60,000 hits on the website is more than we've had on the UHS website, for example. So there is great interest here. And you can see several activities in the month of March that have occurred either last night or will occur over the next few weeks. You know, trying to reach out to folks in Tompkins County and in Broome County and Chemung County, Steuben County. And all of these efforts have begun to make a difference. Here's another example in Chemung and Steuben, a seminar that was held last Thursday. And you can see that trusted faces and trusted voices matter in communities where there is hesitancy about the vaccine. So Corning has been a great partner with us. The health services manager there, Crystal, pulled together 4 physicians, 3 physicians and 1 PhD, and you know this medical panel, once again, trusted faces, trusted voices, so that the underserved community or folks in different neighborhoods could hear from experts that that will make a difference for them. And really hats off to Crystal and others and you know, the western part of our region to do this. And this was very, very successful. And it was the night before a pop-up pod at the Friendship Baptist Church in Corning. So that really made a difference. So one of the things that we continue to look at is, you know, what does the data tell us? When we look at all of our 8 counties in the Southern Tier region and the social vulnerability index, and the higher the score, the more risk. And this, you can see the map of the counties in the upper right. You can see the scores, and we did a lot of work with this over the first couple of weeks of putting our plan together. And just for Broome County, you can see pop-up pods where we potentially will go, and you can see a greater density in Western Broome, less density in Eastern Broome. And you know, trying to map where the potential concerns might be, where we need to go into neighborhoods, where we need to go into fire halls and Deposit or Windsor, and you know, where we need to go to Whitney Point or you know, wherever it may be. And you can see some of the other ones in some of the surrounding counties, and just trying to figure out. And this is just only the 65 and older age group, but we mapped this by every ethnic group, by lots of different neighborhoods, and this is just an example. There's about 20 pages in our overall Southern Tier Vax plan that speaks to this, and every county, and there's 62 you know, across the state, every region has done work like this. Because yes, a mass vaccination site in Johnson City, one to be set up in Corning soon, or the State Fairgrounds, or Yankee Stadium, or wherever it may be, those are great, and they deliver vaccines efficiently for folks who can get there. But for folks who cannot get there, or might be homebound, or might not have easy transportation, or might be hesitant for a variety of reasons, we've got to find different ways to make sure those folks don't get left behind. So you've probably heard and read about pop-up pods. Pop-up pods are sponsored by the state of New York, with vaccine coming from the state of New York. And we've done 7 so far in the Southern Tier region. We did one at St. Mary's in downtown Binghamton. We did one at St. Ambrose in Endicott. We did one 2 Fridays ago at the American Civic Association. Very, very successful. We did 2 in Chemung County. We did 1 in Tompkins County. We did 1 in Steuben County. at the Friendship Baptist Church. And when we're delivering a couple hundred vaccines each day, that adds up and it makes a difference. And we believe that we need to do more of these. We've got multiple requests into the state for every county to do more, to get into rural areas, to get into, like I said, fire halls and VFWs and parking lots of grocery stores and Dollar General stores, and wherever we can reach out to folks and bring the vaccine to them as opposed to them going to a mass site. So we've done over 1,500 folks. They're not easy to do. They're complicated. And for example, the American Civic Association, we got approval at about 3 o'clock on Wednesday. And by 9 o'clock Friday morning, we had to be ready. We had to be ready to go. And Myra and her team reached out to people. We got 258 folks vaccinated that day. And also had a waiting list of over 100 people. So, this outreach of making sure that people are spoken to, ready to sign up, ready to come in, find a way to get there, or us helping with transportation so they can get there. All of that has made a difference. Here's some pictures from the American Civic Association pop-up pod. And, you can see that we needed a lot of staff. We needed a lot of support people. Obviously, everyone masked and protected. And language access, the person on the upper left who is standing is the interpreter in this particular case. The person in the yellow coat in the upper right is the interpreter. So lots of challenges to get to these unique populations. Bottom right, picture of myself and Mayor Rich David and Myra and other members of her team who, like I said, just really made a huge difference in making this work. And a pop-up pod is not a singular effort. It's not just the American Civic Association, for example. It was folks from UHS, folks from Lourdes, scheduling and outreach and supplying the venue, the United Way, Lori and her team, reaching out to people, making phone calls, Broome County Office for Aging, which have been a great partner and helping people get scheduled and helping them find the right place to go, or if we're coming to their neighborhood. A great partnership with Jason Garner and Mayor Rich David and everybody else. But these are the types of things, and we did it. Like I said, this was one of 7 we've done so far. There's another one being done in Chemung County today. That's number 8. We'd like to do double this effort. We'd like to do one a week if we can in some neighborhood or some rural area, because that's what's going to make a difference. And yeah, we're very proud of 140,000 first doses being given in the Southern Tier, but we need to do more. And even with that effort, we're doing about 3,000 a day. In order to meet the expectation that the president laid out last night, we're going to have to do double that, 6,000 a day. So all kinds of partners, hospitals, counties, lots of providers, all of the pharmacies are going to have to continue to work together. And like I said, we want to do as many health equity pop-up pods as possible. I appreciate the opportunity to talk to you a little bit about this. Like I said when I started, this is a historic public health effort like nothing we've ever seen in this country ever previously. And it feels that we're beginning to make progress. And I hope that you all appreciate that and see that, and all of your support, all of your partnership has made a difference in this process. I'm happy to take questions or comments.
I'm not seeing anyone raising their hand or writing anything in the chat.
Can I ask a question, please?
Sure, go ahead.
Yeah.
I see your hand up there with your picture. Go ahead.
Yes, I know in the Health Equity Task Force, we talked about the possibility of veterinarians vaccinating to access maybe farmers and those. I was just wondering if there's been any movement on that.
we're continuing to try and figure that out. Um, Farmers per se are not eligible yet, I don't think. I think more folks are going to be eligible quickly, and the sooner we can get to 1C and 2A and all of the other groups that the state has laid out, I think the better. I think the state of Alaska is the only state right now that has said all those over the age of 18 are eligible. That's essentially what the president said last night about where we want to be on May 1st. I would like us to be there quicker, but a lot of this, as you know, has been about the vaccine supply. Last week, we got over 1 million doses for the state, and that was 3 or 4 times what we've been getting up till now. So we really hope that continues. All the news coming out of Washington seems to be more positive about supply and access. So those are good things. But I think the sooner we can get onto farms and paying attention to migrant workers and other folks who might be underserved, the better off we'll be.
We had a specific question from Teresa. Does the 140,000 vaccinated include people in Tompkins County?
Yes, Tompkins County is part of the 7-tier region.
Okay, and then Mark Rapecki, I understand, has a question. And then Sharon Chesna has a question.
All right, thanks, Lenore. John, I was wondering if you could comment on the availability of the Johnson & Johnson vaccine. And then I had heard earlier this week about the state exploring maybe utilization of that vaccine in rural areas by means of mobile transport. And that was a very new thought, but maybe just share any additional information as you have on that, especially for people in some of those hard to reach areas.
Sure. Thanks, Mark. J&J vaccine has been made available to hospitals at this point, and the intention and the guidance from the health department was for us to use that one-shot J&J vaccine for patients who we are discharging. We've done, I don't know, maybe about 100 in the last week at UHS. I think Lourdes has done something similar, maybe not quite as many. It's a logistical challenge, as you can imagine, Mark. Going from room to room, it's kind of like going from door to door out in the rural areas. Once you puncture the vial, you have a limited amount of time to get those 5 or 6 doses out of it. Not every one of our discharge patients wants the vaccine. We need a doctor's order for that. It's fairly complicated. Broome County got 300 and gave 150 J&J each to Lourdes and UHS, and we've been using our home care agencies to vaccinate folks. And I know yesterday, UHS Home Care did about 25 vaccines in their rounds going to home care. We have 375 people on our home care census. We did 25 yesterday. Each of those visits to a home, not including the regular home care that we're doing, but the vaccine part, takes about 40 minutes, 10 minutes for registration. And instead of just waiting the normal 15 minutes to make sure people are okay, we've been waiting 30 minutes because oftentimes folks are alone there. So, so the homebound or those getting home care is a good use of the J&J vaccine because you only have to go there once for that process. I've heard also, like you, that the state is contemplating using J&J, depending on the supply, for other hard to reach populations or better off only reached once populations. So we shall see how that plays out.
Sharon, your question?
Yes, thanks. John, following up on really what you just shared, my question was with respect to the homebound. And I had seen, and as you just referenced, that you're distributing through those who are currently on your enrollment in your home care, systems. But what about others?
Very interesting question, Sharon, because just today and about 30 minutes ago, we submitted a homebound proposal to the State Health Department for the entire hub. And, you know, we've got different, you know, homebound needs, and there's several thousand homebound folks in the Southern Tier. We are talking about going to congregate housing and you know, really attacking those. And there's dozens and dozens of congregate housing where folks are in fact homebound who have not yet been vaccinated, who can't get out. So that's part of the plan. We've also got a kind of door-to-door, farm-to-farm homebound plan, which is not the most efficient way to deal with a scarce vaccine supply, but it's something that we need to do. So our plans do address in all 8 counties, literally going door to door. For example, when we talk about Delaware County, we might have a mobile strike team, if you will, mobile vaccination team, deliver 4 or 5 vaccines in a day. Because of travel time and this you know, vaccine viability time that we have to play with. So it's going to be a logistical challenge to get to the homebound and figure out how to make it work in some efficient way. You know, I looked at the plans that Long Island and Northwell put together, and on a good day, their mobile strike teams are getting 6 patients during a day. So it's going to take multiple weeks and months to get to everyone.
We have another question from Pam.
Thanks, Lenore. It's actually, you've answered the question, so it's more of a thank you, John, on 2 fronts. You know, Care Compass has done a great job executing the care transition project using both a clinical and a community-based model. And on behalf of especially our rural residents out at Little Delaware Valley Hospital, every vaccine counts, every one matters. So thank you. It's what the patients and the family members have been asking for. So my next ask is, please, in that plan, be thinking about the related family members who also hopefully will now be eligible, and to get it into their arms so that the person has a safe discharge plan and the family has a safe and protected environment to support them in their disease management. And then secondly, thank you so much to the hub for agreeing to put the Get There call center number and website right on your homepage. In the words of Bill Wagner, our mobility management director, no transportation barrier should get in the way of anybody in the Southern Tier region of getting the vaccine. We've got the resources, we have CARES Act money, we've got the broker relationships with whatever that modality is going to be, and we've got the efficient services and vendors and providers lined up and ready to go in a variety of push in and pull out ways. So send them our way, we will take care of them. And I like that you said many times, get there, because that's what the program is called. Yeah. We will get them there. You get them to us, we will get them there. Thank you.
Thanks, Pam. Two comments quick. Our homebound proposal does recommend that we hit everybody in that home, not just the person who is homebound. So, you know, frankly, we'll see if the state can put their money where their mouth is about getting people vaccinated. You know, pardon the editorial comment there. But I think that's what we need to do. I mean, because we can't go back, not at 4, 5, 6 a day. It just doesn't make any sense. So let us widen those swim lanes and do what we need to do. Yesterday at the Regional Advisory Task Force, Bill came on, talked about transportation, and he said exactly what you said. Transportation will not be a barrier in this region, and we will figure it out one way or the other. And he said there's no problem that he can't help solve. I asked if he wanted to help on the homebound problem. He wasn't quite sure about that quite yet. But transportation and the work that Bill and Jack and others are doing is fabulous. And I think Bill said that we are now seeing about 10 to 15 people per day seeking transportation to get to a vaccine, and that's up from 5 to 10 a couple weeks ago. So 15 people a day that we can help and figure out a way to get them vaccinated, that's going to make a difference. Thanks, Pam.
Well, thank you, John, for the update and for your leadership in this effort. You really underscored the importance of the collaboration that's needed to help us get over this hump. We are actually at the end of our time, so I'm just going to turn the meeting over to Mark very briefly for him to make a few comments. Mark, if you could.
Okay, thanks, Lenore. And one additional thing on the vaccination effort, what Bill Wagner also made a point of emphasis to say, although the name of our company is Rural Health Network, the Get There call center, the transportation services are for all areas, not just exclusively rural. So I think it's an important note to add in there. And I also echo the appreciation for John and his team, the reports, the thoroughness, that there's a lot that's going on behind the scenes. So on behalf of everybody here, John, really thank you so much for championing the effort. So I want to give, and I recognize that we're at time. I'm going to try to take maybe around 5 minutes here for strategic planning updates. I want to start also by thanking our strategic planning work group that's been supporting us. The names are here. The slideshow will be out so you can appreciate them separately, but a lot of effort from these folks. They've been meeting with us every 2 weeks since late last year to advance our planning. And if you go to the next slide, Alexa, I have to be cautious not to say Alexa's name too loud, otherwise everybody's home devices might start talking with us. So CCN, as you may be aware, has a strategic plan for the post-DSRIP environment, and that's where we are right now. And there's 3 core elements that our strategy calls for us to organize around. So I just want to repeat these here because any and all of our planning that we do hereafter focuses on the ability to achieve these things. So one, the hallmark of what Care Compass has been able to do is convene stakeholders that haven't previously worked together, share results, do common trainings. So that's something that we want to see Care Compass continue to do in the future. And this meeting is an example of that. This is just a quarterly stakeholders meeting from all 9 counties coming together. And we'll continue to do things like this as we go forward. But there was a secondary item in here, which was we want to see Care Compass support the network with services for network formation and also for services of network operation. And we teased that out a little bit over the past few years by means of the cohort program, but we want to continue to see that excel. We want to see sustainability funds reach their way to the partners. We want to see sustainability funds come their way to Care Compass Network. And a lot of our competency and skill set is specifically around the ability to organize together as a community towards a common purpose. And so that's really the main points of network formation and operation. But lastly, we want to continue to challenge status quo. We want to be a catalyst for innovation. And I really appreciate what the IT team reported on with the CTAP program earlier this year, or earlier last year, I should say. But that came out in March of 2020. And it got recognition from the state. They took that model. They were saying, what is the role of a PPS amidst the pandemic? They shared that, and that got broadcasted to all the PPSs. Peggy Chan was excessively grateful for the level of work that we did with that one. And that's really a highlight of what the Department of Health expected from Care Compass Network. They said, we don't have the ground game. We can't effectively reach the community the way that it needs to get reached. And so that CTAP program is a really good example of how ground level services and reaction can be given to the current needs. Now, we never organized or prepared to do pandemic response, but I was happy to see that we had a way to support it. We can go to the next slide here, Alexa. So there's 4 key goals to our strategy. These were approved by our board of directors last year. First and foremost, we're really looking at sustainability. We do have DSRIP reserve dollars, and they're going to go out for a variety of purposes. But we want to look at how can CCN and its partners be positioned for sustainability outside of those DSRIP dollars. So we're now in a glide path period. We set off a multi-year transition period, and we're starting to see how can we support that and measure the past results and all those sorts of things. The second one, this is directly from the vision statement. We want to prepare and organize networks for participation in value-based care. A lot of our partners are struggling to engage, maybe not getting the attention. They don't have the attribution or the critical mass. And we want to see how can we not just take the lessons learned from the DSRIP program, but better represent and organize the partners to be able to get that sort of attention and experience. We're expecting there to be infrastructure or data needs to equip partners to be able to do that sort of work. So we already have some solutions in play by means of care management and population health services, but we want to stay nimble and be able to look at what other data systems might be needed, such as those that can inform timely data at the point of care. And then also work to help forge productive partnerships with those who pay for care. So we go to the next slide, Kayla, or not, sorry, Kayla, that's a force of habit. Care Compass today exists in this format, and I just wanted to show this out here. Some of this might be new to some of you, but we as an organization today, there's two entities that comprise Care Compass Network. So for one of them is Care Compass Network, the 501c6, the very unique not-for-profit model. It's called a business league. And within that, we do a lot of the activities that I've already mentioned. One of them is we're a convener of stakeholders. We've been a catalyst for innovation. Under those objectives, we've done things like promote learning collaboratives. We've done a lot of workforce efforts, including training and well beyond training. We make knowledge base and content available to our partners. There's one here that's in our plan, but it's not something that we've acted on thus far, and that's advocacy. There's a strategic advantage in being a 501c6 in that you can essentially have unrestricted advocacy or lobbying needs. And as we look at the future development of sustainable models for our partners, that might be a new feature that we activate and deploy. And the last piece here, Care Compass Network is the sponsoring entity for a new not-for-profit that we formed last year called the Care Compass Collaborative. The Care Compass Collaborative is a charitable not-for-profit, which essentially serves as the foundation or the granting arm. So the DSRIP program has ended, but we are looking at how we can secure additional grants for the region. We are already starting to either support partners in their granting process, providing data to them for their granting process, or also applying directly for grants. So Care Compass Collaborative is a subrecipient of a Cabrini grant this year. We also have several other HRSA and RCOR grants that we've supported or led the application effort in. But this is when you look at Care Compass Network, there's this variety of entities that have merged together to sort of support the mission and the ability to move forward. If you go to the next slide, when we look at stakeholder engagement, as we defined it today, as we sort of experience it in this meeting, stakeholder engagement, this is an open opportunity. All partners are welcomed and invited to the stakeholders meeting. All partners have the ability to review the content and have access to that information. And we're starting to refer to that as an open network model. It's a learning collaborative. It's really, we're promoting that collaboration opportunity. And as we go forward, one of the most recent, we just had a board meeting earlier this week. The board endorsed the continuation of planning under two separate, I'll call it network models. One of them is this open network where we can have a baseline of opportunities available to our partners. And Alexa, if you go to the next slide here, the secondary one is a performance network. Not all partners will be maybe interested in some of the performance activities that we've been talking about, but would really enjoy the chance to work on the open network basis. But some might want to work on the performance level or the performance kind of activities. So we're going to start to structure a way for partners to engage with CCN either on the open network or on both the open network and the performance network side of things. And we'd also want to consider how to make ways available to partners who maybe aren't ready for performance level activities today to build those competencies while they're in the open network and begin to move forward if they so desire. So if you go to the next slide, I'm not going to go through all of this. I saw there was a question in the chat. Yes, the slides will be available. These are some of the concepts that we really look at the performance network organizing around. This is highly draft at this stage. We're still doing some planning. The strategic planning groups put a lot of effort into this, as well as the board. So we're still working out some of the details of how this would be structured. But if you go to the next slide, and I think this might be the last slide, yeah, we're talking about some new capabilities. So I've added in blue font here on Care Compass Network. This is where we'll start to organize those open network activities. These are things that would be available to all the partners. But then we're starting to look at what are those attributes and functionalities of the performance network. And so there's some illustrative examples there of the types of things that we'd expect to see the performance network do. And we have to find the way of how we house and deliver those as we go forward. And that's where the current planning is underway. So I believe if you go to the next slide, that's the wrap up. Great. So the planning team has put a tremendous amount of effort into this. Lenore, many of you are here on the call. So thank you so much for all the planning. The temperament and the mode right now is very, very high paced. And so that's the last comment I want to read to the group. I know we haven't met since last quarter, but the group has been meeting very, very actively. There's a lot of challenging details to work through, and we've been making progress on that. But the board has also put down an expectation of expediency. So we're working as hard as we can. We are making a lot of progress on this, and I look forward to more updates at the RPU meetings. We're going to do a form of a listening tour over the next month where we can go deeper than what we just did at the upcoming RPU meetings and be able to get more commentary and question than what we might be able to get in one meeting here. But Lenore, I'll hand back to you and happy to take any questions if we have time.
Well, if we have time, right. Yeah, we are well past our time. I think the opportunity to ask some of the in-depth questions will occur at the RPU meetings. So I encourage people to attend those meetings. These are important developments in the direction for Care Compass Network and for the collaboration of all the partners. You can see we have been through a lot the last year, and it's really that collaboration and open dialogue that has helped us continue to be able to forge ahead in the transformation of healthcare and the improvement in the delivery of services to clients across our region that is critical to going forward. So please attend the RPU meetings. In addition, there's a couple save the dates here on the last slide. So put those on your calendar. They've been very well attended meetings and I think deliver valuable information. Thank you for your service and thank you for staying with us despite the fact that we went over time. So thank you everybody for your participation. Like always, there will be a survey that goes out for you to be able to critique this event and to provide input into future events. So thank you everyone.